Good evening. Welcome to the MyCP webinar series. My name is Paul Gross. I'm your host, as I am on most of these. Tonight, we're going to talk about a really important topic called priorities in adult cerebral palsy research. We've got a good crew of people to talk to you about the process we plan to run, including the principal investigator who was funded for this work, Dr. Cristina Sarmiento. What I like to do on these first, for the people that are not familiar with the CP network, is take them through that with a little introduction. People that have come to a lot of our webinars or have already been members can feel free to tune out. And then I'll turn it over to Dr. Sarmiento and her crew to present priorities in adult CP research. And then at the end, we'll have a discussion. So lots of opportunity for people to hear more details about our plans and figure out ways to get plugged in. So the mission of the CP Research Network is to optimize the lifelong health and wellness of people with CP and their families through high quality research, through education, and through community programs. The network was founded in 2015, and it's a merger of both CP Now, Michelle Schusterman's company that she founded out of her after her CP Daily Living blog, which was very focused on education and produced the award-winning CP Toolkit, which we serve up to people on our website, and a lot of our hospitals distribute to patient families when they get a new diagnosis. So we focused a lot there. On the research front, we were really founded around the concept of creating a national registry, which we launched in March of 2016 and now has more than 8,000 patients in it. And we also launched a community registry to capture information for people just living out in, not coming into the hospital. And that's currently got 2,142 people in it. And that was launched in March of 2019. We're patient-centered from the outset. We ran a big program to gather input from the community, mixture of clinicians and broad number of community members. And that really drives our work. And we've gone on to get some significant funding milestones from the National Institutes of Health. And then more recently, we formed a partnership with the largest private funder of CP research in the United States, the CP Alliance Research Foundation. We have 29 concepts or studies under development, various stages of creation, application, execution, 4 quality improvement initiatives, which are another way to not do research, but to improve outcomes. And we're academically focused in the sense that we publish the results of our work. So we've had 11 publications to date, the most recent one from Dr. Sarmiento herself, over 39 academic presentations, and then we've got 5 more manuscripts that are either submitted, imminently being accepted or published, or somewhere in the process of being written. And then on the wellness front, we partnered with the National Center for Health, Physical Activity, and Disability to promote the mentor program to the community. And if you haven't dug into that, I will look on mentor on our website and really consider that. It's a tremendous program for your overall health. So the network is a 501c3 that brings together all these different constituents to collaborate to improve people's health. We have a data coordinating center at the University of Pittsburgh's Epidemiology Data Center. That data center houses our registries, which are basically databases of people and facts about people with CP and details about people with CP. We also have these education and well-being programs, of which MyCP is a fairly central piece. It's free. It's a personalized web portal that gives you access to a number of programs within the CP Research Network, including participating in research through our community registry, just through taking surveys. And it allows you to participate in discussions like this about research, and offers personalized information based on the information you give us. So you can sign up at mycp.org. Just to give you an idea about what registries are, I'm going to take 2 data points: age, which you all know what that is, and then GMFCS, or Gross Motor Function Classification System, which is really a way of categorizing how people move through the community. Do they ambulate independently? Do they use a wheelchair? Do they use a power chair? So this is a very important data point in cerebral palsy. And you can see the distribution of GMFCS in our clinical registry back in November 2021, when it had about 5,000 patients in it. And then you also see the distribution of age. And you see that if you look at the age bars here, we have about 25% of the people in the registry are adults. in the clinical registry. To contrast that with the community registry, which gathers data through the web, and therefore it's people that are online using social media, we get a very different look at both the distribution of GMFCS, and that sort of reflects the bias and the interest level of of the people that are out there on the web looking at research. And then from an age perspective, you see a very different kind of scale for those same age bands, because there are far more adults than there are peds, and those adults such as you are self-interested in seeing research advance, which we love, and we're really excited to talk about that more tonight. So those are our programs. This is a subset of our research and quality crew when we met with Dr. Hurvitz's hospitality at the University of Michigan in 2019. Our educational materials. Down the bottom right is the group of 45 of us that gathered in Chicago to set our patient-centered research agenda back in 2017, and then our wellness program that's aimed at getting people active. So the network is 30 centers spread across North America. The green pins are sites that are collecting data into the registry. The ones with circles are adult lifespan centers. The yellow ones are working on their data collection processes. The red ones are working on their agreements and their compliance, their regulatory work. And then the blue pins are sites that have raised their hand and said that they want to join the network. So I was on with one of, actually I have to add a pin in Wisconsin, in the middle of Wisconsin, just told me they've got everybody on board and they're going to join, and I'm behind on my pins, so I will add that. So I'm going to turn it over to our speakers. So I didn't have enough room with this many speakers to go through everybody's credentials, but we've got a great group of people. Dr. Sarmiento is one of our up and coming rising stars. Don't mean to call you out and embarrass you, Dr. Sarmiento, but really getting awards, doing lots of different research, getting published. It's really great, and surrounded by great mentors, both at her institution and throughout the network. And then Jocelyn Cohen, who is a consumer representative on this panel, but is also our partner at CP Alliance Research Foundation. So she's a co-investigator on this study. So with that, I turn it over to Dr. Sarmiento.
I'm actually going to kick us off, Paul.
I did not know that.
Yeah, I love surprises. That's what I'm here for. So as Paul mentioned, my name is Jocelyn Cohen. I'm the Vice President of Communications and Engagement at Cerebral Palsy Alliance Research Foundation, or CPAR for short. Before I tell you a bit more about myself and why this investigation into adult research priorities matters so much to me, I'll share a visual description of myself for additional accessibility purposes. I'm a white woman with dark brown shoulder-length hair that's down and brown eyes. I'm wearing large tortoise-shell glasses and a green sweater. There's a CPAR-related background behind me that has white and different hues of green. And sometimes I may look like my eyes are looking away from the screen or like they're rolling, but that's part of my cerebral palsy. I was born prematurely and diagnosed with spastic diplegia CP when I was 8 months old. I was lucky that my parents conveniently lived 5 minutes from the UCP Children's Center in our county so that I could get early intervention PT and OT as a baby. I was lucky that I grew up close enough to New York City, where I now live, to get excellent care from a preeminent orthopedic surgeon who specialized in cerebral palsy. And I was lucky that he never let go of his kids, that he monitored and cared for us with no age limit. I needed that when I hit 30 and suddenly lost standing stamina. I was worried I had some other disability because CP had always meant stable instability for me. I knew what to expect with it, so this inability to stand in one spot for a bit without my knees buckling, surely it had to be caused by something else. I saw my beloved doctor and learned how wrong I was, that this change I was experiencing, that this was age with CP. I protested any kind of age being attached to me at 30, and he said, with CP, that's age. And that upended all I thought I knew about the lifelong disability inside my brain affecting my body. It made me start to question everything. As a kid, I'd assumed doctors and scientists had all the answers since CP is so common. And I assumed they'd know how to treat my changing function or that the pain that crops up more than I care to talk about. I assumed that my issues with cerebral palsy began and ended with my CP itself. I was wrong again. And that's why this study is so important, why I'm drawn to it and why it makes me hopeful. Because there are 1 million people with cerebral palsy in the US, and most of us are adults. Each personal experience with CP is as unique as a fingerprint, from our symptoms to our care access to our understanding of what will help us the most going forward. I'll lead focus groups throughout the study to understand and amplify the perspectives of my fellow community members, also that cerebral palsy researchers in the network can prioritize the adult and aging-related studies they conduct to align with the community's needs. And now I'll be passing the mic to the rest of the research team so they can tell you even more about this exciting project.
Thank you so much, Jocelyn, for that introduction and sharing your story and your experiences. I think that helps really set the stage and frame what we're going to be talking about, because that's exactly what Jocelyn said. That's why this is so important. So thank you, Paul, as well, for letting us present here, and thank you all for attending. I will share my screen so you can see our presentation. Hopefully you're seeing regular PowerPoint view and not presenter view. All right, I see some nods, so
Looking
thank
good.
you. Thank you, Paul, thank you. So we're going to be talking about our project that was generously funded by the CP Research Network Accelerator Award, which, as Paul mentioned, is a joint effort between CPRN and CPARF. And so the title of our project is Priority Setting for Multi-Center Research Among Adults with Cerebral Palsy. So just to overview what we're going to be talking about, first we'll describe for you our project. We're then going to review a few different potential research areas that we're going to be exploring in more depth within our project. And then we'll hopefully have lots of time for discussion and thoughts and feedback and Q&A as well, because we'd love to hear from you. Our investigator team, so myself, I'm at the University of Colorado, Anschutz in Aurora, Colorado. Dr. Ed Hurvitz at the University of Michigan Medical School, Dr. Mary Gannotti at University of Hartford, and we already heard from Jocelyn Cohen as well from the Cerebral Palsy Alliance Research Foundation. So a little bit of background, and some of this echoes what Paul has presented us to on the timeline of the CPRN. So in 2018, the CP Research Network came out with its patient-centered research agenda. And the highest priority was exploring further the treatment of pain, functional decline, and fatigue in adulthood. Then in 2019, CPRN launched its community registry, which Paul told us a little bit about. And just as a reminder, this collects patient or individual reported data on function, pain, and quality of life. However, one challenge that we found so far, despite having over 2,000 people in that community registry, is that currently the population of the registry doesn't reflect the diversity of the CP population. So this is one of the challenges that helped inspire this proposed project that we're going to be telling you more about. A little bit more background. So at the University of Michigan, Dr. Hurvitz's Adults with Pediatric Onset Disability group and his collaborators have been studying aging in adults with CP and given us a lot of really great information about different issues that occur as adults with CP age. And a few of the major areas of concern are kidney disease, bone health, and primary and preventive care. And so these are a few of the potential research areas that we'll be exploring in this project, as well as talking a little bit more about with you all tonight. The challenge now is that now that we know these are major areas of concern, we really need a multi-site research program to address these identified issues. So we've identified them as issues, but now what comes next? So the goal of our proposed project is to advance research about adults with CP. We want to use the CP Research Network's infrastructure. As we saw with that great map, there's a whole bunch of different sites across the country that are a part of the CP Research Network. So how can we leverage that to advance research? We want to gather input and priorities from important stakeholders. And our long-term goal is to really form a multi-center research program that's focused on adults and aging with CP. So combining these research centers and clinic areas and health systems across the country so that we can all collaborate and work together and advance research and knowledge and clinical care as effectively as we can. We want this research program to be co-created by consumers, clinicians, researchers, and community organizations. And so those are the voices that we're hoping to hear from in this project. We want to, again, identify these research priorities, identify some new and potentially effective recruitment strategies for research, particularly in that community registry. And we want to engage the community actively to really co-create this research. So what are the aims or the objectives or goals of this particular project? So we have 3 of them. So first off, we want to prioritize and gather input on potential focus areas for this multi-center research program relating to adults with CP from people with CP themselves. We then want to develop more specifics on research projects and recruitment strategies, and we'll do so gathering the input with clinical investigators based on the information and feedback that we get from that first aim. And then finally, we want to engage community organizations and other community leaders to see what they think about the value of our proposed research projects, our recruitment strategies, and also see if they are able to engage in recruitment so that we're really reaching out to members of different communities. So how are we going to do this? Our main research methods are focus groups. And so in that first aim, we're going to hold focus groups with individuals with CP and caregivers. For that second aim, we're going to hold focus groups with clinical investigators. Our third aim will then be focus groups with community leaders and advocates. And we'll talk a little bit more about what is going to go on or what we hope will go on within each of these focus groups. So for our first round, we're planning to hold 2 focus groups with 8 to 10 participants each, drawing from the CP Research Network and CPARF, as well as our clinical sites if we need to. Those eligible to participate in these focus groups are adults with CP that are 30 years and older, and we will also recruit a few caregivers to participate. And we're going to use a sampling technique called purposeful sampling. And so this is where we think carefully about different types of experiences and backgrounds that we want to represent in our focus groups. And so we'll purposefully then seek participants to represent the diversity of these different areas. So we hope to recruit participants with diverse gender, race, ethnicity, gross motor function levels, as well as a variety of life experiences and perspectives so that we can really get as many different voices in the same virtual room as possible. So these focus groups, as Jocelyn mentioned, she will be our leader, our facilitator in them, and they'll take place over Zoom. How it will work is that the clinical research investigators, so Dr. Hurvitz, Dr. Gannotti, and myself, will share knowledge about these potential research areas here in this table. And we'll also share a little bit of knowledge about these areas today so that you can understand why we're focusing on these areas. These topics are bone health, and so some potential research questions that need answering still are: how common is bone health treatment, like exercises or medications, in adults with CP? And for those adults with CP that do get fractures or break bones, how often are they getting physical therapy after those fractures? Related to kidney health, how common is kidney disease in adults with CP? What increases a person's risk for this? And are those adults with CP who have kidney disease or issues, are they getting referred to the appropriate specialists? Related to primary and preventive care, we want to know, are adults with CP getting appropriate preventive screening measures, things like pap smears, colonoscopies, mammograms? And if not, how can we increase the rates of those? And then finally, related to our community registry, how can we increase recruitment? What are the characteristics of adults with CP that have chronic pain and a decline in function with aging? What treatments have people tried and which ones have they found effective? And one important consideration for the community registry is that right now we don't include proxy responses. So we don't include responses from a care supporter regarding the adult with CP. So all the community registry respondents are adults with CP themselves answering surveys for themselves. And this information is extremely valuable and important, but we would also love to be able to include those proxy responses for people who might need the assistance of a care supporter to respond to these surveys. So within these focus groups, we want to gather people's perspectives. So how important do these different areas seem, or are they in your life? What's the priority of one versus the other? What might be challenges to conducting research in these areas, and what might be possible solutions to those challenges? And what might be effective in recruiting a person with CP to participate in a research study? After our focus groups, we'll analyze, categorize, summarize findings, and then we'll be able to send a report to participants for their feedback to make sure we're accurately reflecting and understanding what was said within the focus group. And so these might be some of the questions that we talk about within the focus group. So what has been your experience with bone health care or kidney health care with your team? And what do you feel are the gaps in your knowledge related to these areas? And what about the gaps in clinical care? And what are the most impactful questions for you to answer related to these areas? After this round, we'll then hold one focus group with clinical investigators of the same duration and also via Zoom. For this focus group, we hope to recruit clinicians that treat adults with CP or that are involved in the transition to adult care for individuals with CP. And we would like for them to be a member of the CP Research Network or another CP-focused organization and have interest in potentially participating in this multi-center research program that we're hoping to create. Within that focus group, we'll first summarize for them the data that we gained from the first round of focus groups with adults with CP, and then we'll gather their perspectives on the relative importance, priorities, help shape the design of specific research projects, and seek their feedback on recruitment strategies as well. So some potential questions we might ask, what is your clinical experience with these issues and these areas? What barriers do you see to performing research in this area? And other similar questions. And then finally, we'll move on to our third round of focus groups, which will again be one focus group with community leaders and advocates. Eligibility criteria, so we'll be seeking to include leaders of relevant community organizations, so like United CP, CPARF, and other institutions or organizations that serve adults with CP or individuals with disabilities more generally. We hope also to seek prominent advocates in the CP and disability spaces. And it'd be really great if these participants had the potential to use their platform to share knowledge about future research opportunities for future studies. So within that focus group, we will share data from both of the, or all of the previous focus groups. So you're probably seeing a pattern here. And then we'll get their perspectives on what they perceive as the value of the different research areas, challenges and possible solutions to conducting that research, and their feedback on potential recruitment strategies. So some of the specific questions we might ask them, what do you think are the most impactful questions to answer for your community? And how do you think that your organization might be able to participate or promote this work? So once we're done with this project, with all these focus groups, what do we hope to have at the end of it? So we hope to have drafts of 2 larger grant applications for the next research studies, really focusing on the community registry recruitment and how can we better recruit participants into the community registry so that we get the diversity of people that we need in order to generalize that information to the larger population, as well as one grant focused on that multi-center research study. And so the reason we would like to do these focus groups first is so that these larger research projects are really founded on the priorities of the community and stakeholders. And again, it's all about kind of co-creating that research agenda. And so just a couple points about why is this relevant to Research CP and the CP Research Network. So again, we're hoping to address some of these well-identified negative health outcomes in adults with CP and move to the next phase of research. We want to really incorporate a variety of voices and amplify that community voice. And we want to develop that multi-center research program so that we can then translate knowledge into clinical care. And so this is just a little figure that kind of shows, again, the overall flow of our proposed project, where we seek input from consumers, summarize and share findings with clinician researchers, summarize and share findings with community leaders in order to move that research program forward. So that's an overview of our project. And now we'll just talk about, you'll hear from a few of us. We're just going to give you a little information, a little overview of these research areas that we're exploring more in the focus groups. So that gives you a little bit of context, a little bit of information about why these areas are important for adults with CP. So Dr. Hurvitz is going to start us off in this section.
Thank you, Dr. Sarmiento. So I'm Ed Hurvitz from the University of Michigan. I'm a pediatric rehabilitation specialist who has been treating adults with cerebral palsy for many years. As Dr. Sarmiento mentioned, the presentation you're going to see today is going to be a bit of a shorter form than the one we're planning to do in the focus groups. So I want to talk about detecting and treating kidney disease in adults with cerebral palsy. Next slide, please. So chronic kidney disease. Kidneys, as most of you probably know, clean our blood from toxins, regulate the fluids in our body. They're very important to our functioning. Adults with cerebral palsy have an increased risk of kidney disease. We've done studies using large databases that have shown this to be true. Why is that? Well, many adults with cerebral palsy have hypertension, more so than the general population, and that's one of the main risk factors for kidney disease. What happens when people have kidney disease? Well, it may lead to dialysis or even need for a transplant, so it's very serious. Next slide, please. So what is the problem then about kidney disease in adults with cerebral palsy? What do we have to solve? Well, doctors measure the health of your kidney by measuring creatinine. If a person has low creatinine, it means the kidneys are clearing the creatinine out of the blood, and that means the kidneys are working well. If the creatinine is increasing, it means there's kidney disease. Now, what is creatinine? Creatinine is a chemical we find in the blood, and it comes from muscles. People with cerebral palsy have less muscle. You see the figure there, and a person with cerebral palsy is figure A, and you see the black area, much less muscle mass than figure D, which shows a person without cerebral palsy having much more muscle mass. They're the same age, the same weight, but you see much more muscle in the person without cerebral palsy. Less muscle means less creatinine being formed. That means there's lower amounts in the blood, even if the kidneys are not working well. So the kidneys can appear normal, even if there's early kidney disease, because the doctor will do the creatinine test and it will be low because there's low muscle mass. So how do we detect kidney disease in adults with cerebral palsy, knowing that they have it more often than other people? Next slide, please. So we want to have faster diagnoses and better outcomes. So why early kidney disease should lead to increasing treatment of hypertension, changes in diet. As I just said, the regular screening doesn't work. So what should we do? Well, we can look at the creatinine over time. And if it's going up, even if the levels are normal, could do. Is that a better model? We're not really sure. And at what point do we send patients to see a nephrologist, a kidney doctor? Next slide, please. So our idea is we're going to make a network of clinics using the Cerebral Palsy Research Network. We're going to assemble clinics around the country, and we're going to have people in those clinics measure creatinine in adults with cerebral palsy over time And when people have rising creatinine, we're going to send them for advanced testing. We're going to have them see a kidney doctor, a nephrologist, monitor the outcomes, and see if we can have an impact on kidney disease in adults with cerebral palsy. So that's the plan for the kidney disease study if we decide to do that. Next slide, please. The other study that I'm going to be talking about is bone health in cerebral palsy. Next slide, please. So fractures are very common in cerebral palsy. These images from a study that we did, you see the dark black line represents fractures in people with cerebral palsy. The lighter gray line is people without cerebral palsy. You see in women and females, the lines kind of follow each other, with the cerebral palsy line being higher, so more fractures in people with cerebral palsy. On the male side, we had the very surprising finding that it actually looks very much like women with cerebral palsy and nothing at all like men without cerebral palsy. So fractures are very common and they're a very major problem. Next slide, please. Fractures can lead to illness, to early death. We think about fracture, what the factors before fractures: low bone mass, the bone's not being properly formed. We try to prevent that, but then we see fracture. After the fracture, there's all kinds of problems. You see the list there of various problems that people can have, problems with their loss of function, independence, and all these medical problems that they can have after having a fracture. And that leads to morbidity and mortality. That means sickness and dying for just having these bone fractures. The fracture itself doesn't lead to sickness or dying, but it's all the problems that people get after they have the fracture. We can improve and even save lives if we address bone health and do better screening and treatment in adults. Next slide, please. So we have to do better care for bones. We have to screen for bone health by doing what's called a DEXA scan. You see the image at the bottom of somebody getting a DEXA scan, and the result that we see, it tells us the bone density, how much fat there is in the body, and the muscle mass, all important information for understanding bone health and overall health. And then what about the after fracture care? We did a study that showed that adults with cerebral palsy don't always get PT and OT after fractures as much as they probably should. Well, PT would help increase mobility, and OT can make the environment safer. So we hypothesize that if people don't get therapy, there's probably less participation, less mobility, less moving around, less activity, and a higher risk of disease. So how do we make things better? Next slide, please. So we would, once again, a network of clinics using the Cerebral Palsy Research Network. We would come up with protocols for doing more DEXA scans, and people with low bone density, we would refer them to a bone density specialist. We tell them to increase their weight bearing and figure out ways they can do it. We might try osteoporosis medications. We've done a study showing that it's very helpful when people with cerebral palsy take these medications to prevent fractures. And then better aftercare for fractures with PT and OT, and once again, monitor outcomes. So that would be what the bone study looks like in short. Dr. Sarmiento.
Thank you, Dr. Hurvitz. I'll talk a little bit now about primary care and preventive screening. So some common themes that you'll probably be noticing between Dr. Hurvitz's information in this. So adults with CP have a higher risk of many chronic conditions. And so this includes things like diabetes, asthma, high blood pressure, hypertension, stroke, arthritis, and mental health conditions. And so primary care, what's the role of primary care in preventive screening? So earlier detection through preventive screening and treatment of these chronic conditions is beneficial to health. And so comprehensive primary care and preventive screening can help. If we identify these chronic illnesses earlier and start the appropriate management and treatment, we can have better outcomes. And so just a little bit about what is primary care and preventive screening for those who might not be as familiar. So preventive care includes things like medical tests to identify conditions earlier. And the reason that's important is because most conditions are easier to treat when they're identified earlier. This includes things like colonoscopies to detect colon cancer, mammograms to detect breast cancer. Preventive care also includes services that can help prevent diseases, things like flu shots and dental cleanings. And preventive care also includes education and counseling. So talking about things like smoking and heavy alcohol drinking, diet, weight, and exercise. But we know that adults with disabilities, other studies have shown, receive lower rates of many preventive screenings. And so some of the questions that we still need to answer are, what are preventive screening rates for adults with CP specifically? So the prior studies have been done in adults with disabilities in general, but can we look at all of these different preventive screening items for adults with CP? And what are barriers to getting appropriate preventive screening for adults with disabilities in general, and then with CP in particular? And how can we improve this? And so how can we utilize that CP research network infrastructure and network of clinics in a potential research study? So again, we could assemble these clinics from around the country using the CP research network. We can measure current rates of preventive screening. We can explore with adults with CP, what are the barriers to getting this preventive screening and what might help improve this? And we can also develop and then test tools to educate adults with CP about the importance of preventive screening, what screenings are due when, so that we empower individuals to know this information about their own health. And now Dr. Gannotti is going to talk to us about the community registry.
Excellent. Thank you so much. I will talk to you about the adult surveys on function and pain. Next slide, please. And I'll talk about why a patient-reported registry was created, what we've done, what we found out so far, what we're doing now, and what we want to do next. Next slide. So why a patient-reported registry? If you look at the image I have with the bar graphs here, this is patient-reported information. This is information from women who have breast cancer, and they put in information about themselves and how they felt about their symptoms and their quality of life. And we probably have this 1 year before diagnosis retrospectively, or done, before they actually after they got diagnosed. But then at different time points of their treatment, during radiotherapy, chemotherapy, 1 year post surgery, 5 and 10 years out. And you can see the symptom burden and the change in health-related quality of life during chemotherapy. And that's good evidence for clinicians and for programming and policymakers about a targeted area of where to support people when they're really vulnerable. So patient-reported registries have been used in lots of other diagnoses to inform research and clinical care. And in fact, the Down syndrome registry is very similar to the CPRN registry in that it's collecting lifespan information about functional changes and pain in people with Down syndrome. And their goal is 10,000 people. And I think right now they're about 5,000 or 8,000. So patient-reported registries are a really important form of information for research, policy, clinical care, and patient information. Next slide, please. So what we've done so far is identified priorities, functional changes in pain, created an online community and platform for administrating them at MyCP at CPRN.org, launched the registry in 2019, primarily using social media outreach. And then we've created initial reports, and as Paul indicated, Dr. Sarmiento's publication on pain just came out in Disability and Health, and hopefully there'll be other publications forthcoming. We have an initial sample of under about 200 people, and it's biased because it's primarily women, when we know that it's not balanced with gender, but we still have some information. Next slide, please. So what we found out so far, and many of you probably know because we've presented on this before, that functional changes and the percentage of how it changes among different levels of functional capacities is different. And we can see that there are folks that are more involved. As you get more involved, you have a higher risk, and there's a ceiling and a floor effect. And then we see with age, also an increased frequency of reported changes in age. We've gotten some reasons for functional change that are very compelling and have inspired surveillance and further research and quality improvement projects. And then we've identified an average number of 8 sites for pain, with low back being the most frequent, and very poor management of pain by patient report, that 70% report that is very poorly treated. Next slide, please. So what we're doing now is we've gotten a little bit of funding from the American Physical Therapy Association and Riften Products. And we've been able to engage Cerebral Palsy Foundation with providing targeted emails to their members to participate in the adult surveys. We have 2 sites that will begin recruiting, Michigan and Gillette, in their adult clinics. And then we're exploring collaborating with the Cerebral Palsy, United Cerebral Palsy, if we might be able to work with those community organizations to recruit more people. And we've dramatically increased the enrollment, but we still are leaning towards not quite the diversity that we want in functional levels, gender, and racial diversity. Next slide, please. So what we want to do next is write a grant, create some research, figure out some different ideas for recruitment strategies, possibly looking at expanding from 2 sites to more CP research sites. Try and figure out ways to engage people in the general community. A lot of people with CP do not receive care at the Cerebral Palsy Research Network sites. And then how do we engage people and inspire annual participation? Because it's that longitudinal follow-up, as I showed in the breast cancer graph, where you can follow people over time, that really gives you insight into the natural history and targeted areas for support services, intervention, and prevention strategies. So we're looking for ideas, and that's what we'll be gathering in the focus groups, and we'll welcome those now. Thank you.
Thank you, Dr. Gannotti, and I'll just correct her. So that paper was also included authors Dr. Gannotti and Dr. Hurvitz, as well as several others. So a big team effort. And Paul, yes, as well. I saw his picture just popped back up on my screen, so I need to make sure.
I stood up so that you would acknowledge that I'm not just
Perfect.
kidding.
Great. Well, I'm gonna stop sharing so we can all hopefully see each other a little bit better. But would love to hear any thoughts or feedback or questions for any of us.
And you can feel free to you can raise your hand if you can figure out how to do that. I can get lost on that at Teams for a technology guy. It's kind of sad. Or you can put something in the chat and we'll just try to balance going through.
And I'm going to be taking notes too, so please excuse my typing as we talk.
I'll ask a question since no one's asking. Is there any chance? How might a different research question get considered that's not in the list of things that you guys have targeted as areas where we need more evidence?
I think that's a great question. I think there are so many questions to be answered about the health of adults with CP and how to promote healthy aging. And so I think we tried to choose areas where there's enough of that kind of foundational research that we really are ready to take that to the next step. But these focus groups will be audio recorded and then they'll be transcribed. So we're going to be able to have all of the information shared in these focus groups. And again, I think this is really the springboard for these next steps. And so we would love to hear additional future ideas. I don't know if anyone else has other thoughts to add.
I was just going to say, I think if the focus groups tell us, no, those are 3 very dumb ideas. You need to do this, that, and the other thing. Well, we're there to listen.
Mm-hmm.
Okay, June has her hand up.
Yeah.
Mary, were you going to comment? I'm sorry, was somebody else going to comment on? No? Okay, go ahead, June.
Yeah. Well, this is all overwhelming. the money doesn't exactly fall off of the trees. So I had a couple general questions, and are we looking at why people aren't receiving care at these CP sites? Are they really what we think they are, or are they something else? Or do they have more limitations than maybe we want to recognize? So I think that's all big question. The other is to think about carefully, you can't do it all. So how are you going to prioritize all this? What's going to come first? And I'm concerned about these focus groups, having done many of them. They're so labor intensive with very limited numbers that you're really talking to. And there are a lot of new, crowdsourcing models that may be more inclusive to look at. You do surveys, but Paul, that whole virtual process that you went through years ago with adults with CP, I was impressed by, how you did that, how things got prioritized and kind of brought down to, really honing in on the question. So I do worry about over involvement of focus on focus groups versus really exploring some of the newer ways to be more inclusive and get more input. And in terms of the diversity of the registries, I think we need to think about the fact now internet is a very white kind of a thing still. And, are we reaching out to people who rather do phone surveys or, the more intensive stuff? So just a few things I'd like to address, but I do have a lot of concerns about the focus groups. I don't know.
So June, I appreciate your comment about the internet surveys the internet is very white, and there's also a big mistrust to put your information in. So we are looking for different strategies for connecting with people through different ways. And I think there's some good models out there, but are going to require some sort of financial support to have community ambassadors.
Mm-hmm. Yeah, money.
That's a good point.
Yeah, when we think about the prioritization, you mentioned the exercise that we did a few years ago that Paul put out that thing on the internet. That was really like a first phase of this. That told us that what people want us to do is look at health outcomes in adults with cerebral palsy. That rose right to the top. So that was the first prioritization. Now we need to get a little more detailed, and we need to hear from people with cerebral palsy the thoughts we have for these studies, what they think is most important, and what are some of the barriers. Now, the truth is, just we've been talking to Jocelyn about these things, and she's given us a ton of information that's very useful. I think if we talk to another 20 people with cerebral palsy, we'll probably, have so much information, our brains will explode. So I don't think we can talk to any more than that. So we'll start with focus groups, and we'll see where that takes us.
Well, do we want to re-engage in that process again with those more targeted questions? Kind of take the process that was done and hone it?
Let me say this, June. So I think you've raised issues. I think the team's aware of them. I want to give, because we're kind of low on time, I want to give other people to talk. I certainly would be open to supporting something that would complement the work that the group is doing. Focus groups get different information than Code Digital does, and so anyway. But it's all good feedback. I want to there's a question that's repeated several times in the chat that I want to put out there. A number of people have said, I'm really interested. I'd be glad to be part of a focus group. How can I be considered? So can you guys address that?
Yes,
I was messaging people directly and then saw so many people say it. I just put my email in the chat. I feel like that's the easiest way to do it right now.
Okay.
The chats die when the Zooms die, and I don't want to. So if everyone asks that question,
I get them. So, but
yeah.
but that's That's fair. So that's great. So that handled
Yeah.
that. I didn't see that you had done that, Jocelyn.
I did it right
scrolling.
as I was typing that answer as you were saying that was a thing people were asking about. So if you put a note in the chat that you're interested in potentially being part of the focus group, I just chatted to everybody with my email address. So please email me, like grab my email from the chat and email me. And we did mention you have to be at least 30 years old to take part in this. So that is one. And now I see Morgan. You popped into my head and I was like, she is too young at this time to be part of this study. But yes, please email me and we will put you on the list for potential focus group participants.
Great,
Yeah, I
thanks.
think
John
it will-
Borland, I'm sorry.
Just,
Go
it
ahead,
would
Mary.
help, Jocelyn, if you tell, if we have a little bit of information about functional ability.
So even if you don't know your GMFCS level, share whether you walk or not, if you do so independently or not, and how often you do that and or use an assistive device. Because not everybody knows their GMFCS.
I assume you'll come back to people with clarifying questions too. So,
Of course.
John Borland, then Seth, is it Dibble? Seth Dibley. So go ahead, John.
Well, actually, that was going to be my question also. I was going to put voice to what I was seeing in the chats and they got ahead of me. But
Okay.
really very much interested in, I'm really excited to see finally we're putting a focus on adults. And I would very much like to participate in the focus group.
Okay.
Thank you so much. It's so great to hear everyone's excitement.
Seth Dibley.
Well, hello, everybody, and I apologize for arriving late. I got hoodwinked by the time zone, so I've only heard the last half hour, but it sounds like it might have been the better half hour. My experience is that good research takes a long time to get into practice. And so whatever you learn that can be accelerated, that can be translated into work on the ground, sooner the better. And I think that's just the way it's built. You have a finding, it gets published, it gets peer reviewed, it gets it into a textbook or it gets into a training program, and then finally a new graduate gets it. And I think when we have some discoveries like we have with kidney function and people with CP or creatinine or what was the other one I was thinking about? Our primary care docs, they don't even realize that. They're going by the printout that they get from the hospital that tells them what's above and below normal. And so they need to be primed to look for that. And the physiatrist isn't going to do that. My physiatrist is top drawer, but he's not going to look at my GMF. So I feel like somewhere there's a gap that needs to be closed with primary care.
Yep. I will say to that, so first of all, part of what we do in the network is we do quality improvement. And what's different about quality improvement versus research is it's not trying to generate fundamentally new knowledge, but what it can do is improve care in a very short cycle. Like we've been able to change the assessment of pain very quickly, and we're going to now approach the classification of pain and then treatment of pain. So we can change things very quickly and we can implement that across the network. But the real translation down to the level of PCPs, I will say the CP Foundation has a very big vision of that and plans to take both our work and some other work that they're doing in conjunction with the University of Michigan and others to actually try to translate that into implementation down at the community level. There's a lot of work to do that, but it's ambitious, but it's the right thing to do. So very good point. Duncan, you're up.
My question is in regards to the general population, like mammography or PSA testing. We generally look at an age when that should start. What is out there that indicates, are there certain decades or points in aging where we should be screening for kidney or bone health or something like that. Personally, now that I'm in my 8th decade, in the last year, I've run into some real significant issues with spinal health. And I look back and think, God, when should I have started screening in terms of my spinal health? And would I be at the position I am now if I had started screening at an earlier, at some point in time?
So let me just start the answer, because, you know, Duncan, some of this relates to the work we've done at University of Michigan. So, for example, that image I showed you about the bone fractures, that tells us that we need to think about preventing fractures much younger in people with cerebral palsy. It also tells us that, you know, we classically think about sending women in their 50s and 60s to the doctor to get osteoporosis medications. But we need to think about that for men and women with cerebral palsy, perhaps in their 40s. Some of the goals of these studies that we talked about are to try and define that a little better.
So does that mean that we should be looking at trying to establish certain baselines at some point in the aging process? And once again, it's a personal issue. Right now, I wish I had a baseline of my spinal health at age 55.
It's an interesting question.
I'm sorry, go ahead.
Okay, that's an interesting question, Duncan. I mean, it's not our practice to do that in people without cerebral palsy, but because cerebral palsy have a higher prevalence, higher amount of this problem, maybe we should think about it. Haven't thought about that. We'll have to think about that, Duncan.
Thank you.
So I want to be conscious of the time because it's late on the East Coast. It's early for me. Amber Gorman, you have a question. You've got the floor. We're going to wrap up probably after this question. You're muted.
It actually piggybacks on what Duncan was talking about, as far as if we know that bone health, kidney stuff, and PCP issues are, you know, more prevalent earlier, then shouldn't we be doing baselines earlier? I mean, I'm 2/10 of a point away from being osteoporotic, and I'm in my early 50s, but the only reason I know that is because I was persistent with the PCP on doing a bone scan, or I'm sorry, the GYN, to do a bone scan. But I had to really like give her good reason, you know, like give her very evidence-based reasons as to why it needed to be done. And she entertained it, but didn't think it was going to come out the way it did. So I think education earlier for not only caregivers and people with cerebral palsy, but also medical professionals, because they're just going by the numbers strictly. You know, well, you're not 50 yet, we don't do that until then. But I have these other things going on, so, you know, shouldn't we do this earlier to have a baseline to check things? I mean, and I mean, in maybe some cases it will come out fine, but if we already know this, then you know, chances are, you know, because bone health, from what another doctor told me in CP, or actually in all women, he said, not even just women, not even just people with CP, he said it should be looked at in your teens, because they can actually predict whether you will become osteoporotic when you're older. That's what another physician of mine told me. But they don't, because that's not the standard, of course, for anybody, CP or not. But and then I think really educating parents so that they know what to be looking for or asking for earlier, and then then educating teenagers so that they have better, they can transition themselves when they're adults and they have better tools to be able to do that. And then adults with CP who are obviously getting missed. And I would imagine there's a lot of different factors because of that. And then probably GMFC level has something to do with that, and how well you can communicate and what your mobility is, and then how comfortable the specialty physician is with your CP, and how they're approaching it, and what you're reporting to them. Just some comments, that's all.
Oh, I'm gonna,
Thank you, Amber.
yeah, I appreciate that. That really emphasizes, puts a point on the point that John made. So I want to thank the crew that's working on this, in particular, Dr. Sarmiento, for, being the lead on the grant and taking the lead on this really important work. I really want to thank Dr. Gannotti for all the work who worked with many of you to get that initial study up and running, which is now, we're now starting to pay off with all these different areas. And yes, it's got to be more diverse, but it's that investment, that commitment, that period of time that's been invested in that has been huge. Dr. Hurvitz, with all the great work that's going on in Michigan that is being brought to bear here, is just tremendous. And Jocelyn Cohen for being just a great voice and coordinator of the community voice. We really, really appreciate all of you. So thanks to everyone who joined. Keep in touch. Send email to Jocelyn if you're interested in participating, and put up the recording tomorrow. And thanks for attending.
Thanks, everyone. Have a good night.
Thank you.
Good night, everybody.
Thank you all.
Good night.
Thank you.
Thank you, everybody.